Hello everyone and welcome again to the ECG course after long interludes. And today we are resuming our ECG course with a very interesting topic that most of you were waiting for, which is myocardial ischemia. And of course we are starting our course with a preamble to the myocardial ischemia in order to give in this introduction what we are going to discuss in this interesting topic. And of course, as we used to, we are going to start with our ILOs in this topic in the ECG course. We are going to learn the different ECG changes that raise the suspicion of myocardial ischemia, the 3 clinical spectra of coronary artery disease, to understand how to diagnose STEMI, and understand how to differentiate and what's the difference between myocardial infarction and ST elevation myocardial infarction, as sometimes there is some confusion between them, to understand how to diagnose non-ST elevation acute coronary syndrome, and what is the value of the resting ECG in patients with chronic coronary syndrome. First of all, we need to understand some of the pathology of the myocardial ischemia. When myocardial blood supply is abruptly reduced or cut off to a region of the myocardium, a sequence of events occur, and this begins of course with ischemia, in which there is inadequate tissue perfusion, but the tissues are still viable, followed by necrosis, or we call this here infarction, because the necrosis is caused by reduced blood supply, and if this infarction was not salvaged at a suitable time or the appropriate time, it ends up with fibrosis or scarring because this segment was not salvaged at the appropriate time. And so the ECG change occurs sequentially with each of these events. Of course, there are some ways in order that the ECG can change in order that diagnosing myocardial ischemia can depend on them. Of course, ST elevation or sometimes ST depression is one of the very characteristic changes that may occur in myocardial ischemia, and is very characteristic and raising the attention of all the doctors. The T wave is one of the famous changes that occurs in myocardial ischemia, like peak T wave, flattened or inverted T wave, and of course the appearance of pathological Q waves, which is considered like a sign of myocardial infarction, is one of the most important ECG changes that can occur in myocardial ischemia. Of course, the 3 clinical spectra of the coronary artery disease includes the ST elevation myocardial infarction, which is of course one of the very important clinical emergencies in cardiology. We have of course the non-ST elevation acute coronary syndrome, and we have the new terminology of chronic coronary syndrome, which was previously called stable coronary artery disease, but in the most recent ECG guidelines in 2019, it was renamed into chronic coronary syndrome to include different clinical scenarios. Of course, the non-ST elevation acute coronary syndrome includes both the unstable angina and non-STEMI. Regarding the definition of ST elevation myocardial infarction, we are using the definition of the ECG guidelines in 2017, as it defines the ST elevation, which is measured at the J point, as suggestive of ongoing coronary artery occlusion if at least 2 contiguous leads are showing ST elevation more than or equal 1 mm in the absence of left ventricular hypertrophy or left bundle branch block. Although, of course, acute left bundle is included in the definition of ST elevation myocardial infarction itself, if there is no previous documentation of left bundle branch block, or sometimes if I don't have previous documentation, I can consider it, but we are dedicating a specific lecture for the topic of acute left bundle versus chronic left bundle branch block. But the cutoff point of 1 mm is not the same in V2 and V3, as we use different cutoff point in these 2 diseases specifically, as it is more than 2.5 mm in males less than 40 years, 2 mm in males more than 40 years, or 1.5 mm in females regardless of their age. But the definition of myocardial infarction, in which we are using the 4th universal definition of the ECG guidelines in 2018, which is different. First of all, myocardial injury is defined as evidence of elevated cardiac troponin with at least one value above 99th percentile upper reference limits. And we consider the myocardial injury to be acute if there is a rise and or fall of cardiac troponin value. So myocardial injury is just elevation of the cardiac troponin above 99th percentile, and if there is a rise and or fall, so it is dynamic, so it is acute injury rather than chronic injury. Regarding acute myocardial infarction, it includes acute myocardial injury with at least one of the following, which even evidence of myocardial ischemia. Like what? Like symptoms of myocardial ischemia, like new ischemic ECG changes, like development of pathological Q waves, like imaging evidence of new loss of viable myocardium or new segmental or motion abnormalities in a pattern consistent with the ischemic etiology, or identification of a coronary thrombus by angiography or autopsy if the patient unfortunately died. So acute myocardial infarction is defined as acute injury as we defined before, plus at least one evidence of ischemia as we mentioned here. So myocardial infarction, of course, have two classic types which were previously described in pathology books, and of course some of us learned about them, which was classified into transmural myocardial infarction and subendocardial myocardial infarction. But this is a pathological rather than a clinical classification, because I don't see the heart of the patient directly in order to decide whether it is transmural or subendocardial. And it was replaced by something called Q-wave myocardial infarction and non-Q-wave, depending on that the patient who had myocardial infarction showing Q-wave or pathological Q-wave, I call it Q-wave, and this is mostly ST elevation myocardial infarction, and non-Q-wave is a pattern of myocardial infarction that doesn't show pathological Q-wave, and this was mostly the non-STEMI. But of course, we all know that pathological Q can occur in both types of myocardial infarction, and so their presence is not peculiar to this type. So of course, both these types of classification cannot be used to classify myocardial infarction, and so myocardial infarction is classified into STEMI and non-STEMI based on presence of ST elevation and acute left bundle, as we defined in the STEMI, or absence of these features, so we call this non-ST elevation myocardial infarction. And so the ECG classification is based on presence or absence of ST elevation rather than the pathological classification or rather than pathological Q waves. So remember, normal ECG does not exclude myocardial infarction. In up to 20% of myocardial infarction, the patient may have normal ECG. So remember that sometimes the LTX artery or the OM branch occlusion may be hidden, leading to normal ECG despite the patient having typical chest pain, and if you detected the cardiac markers, it may rise. So put this code in your mind: normal ECG does not exclude myocardial infarction. And so from the ECG perspective, we don't depend on the resting 12 lead ECG alone to diagnose myocardial ischemia. Number one, serial ECG of course is very important, because the first ECG may be normal, but the serial ECGs show a sequence of scan changes. Stress ECG is very important in patients with chronic coronary syndrome, because the patient at rest may have normal resting ECG, but with acceleration of the heart rate and the stress, of course, this may induce myocardial ischemia, leading to ST depression or even ST elevation during acceleration and during exercise. The right ECG leads are very important to diagnose RV infarction, and the posterior ECG leads are very important to diagnose posterior STEMI. So of course we know that RV infarction is something very common with inferior STEMI if the RCA occlusion occurs before the RV branch, and its ECG signs depend on the ST elevation in the right ECG leads. ST elevation in lead 3 is much more than the magnitude of ST elevation in lead 2 and ST elevation in V1. And of course, as we know, the right ECG leads is here. We can see here the anatomical orientation. The V1 and V2 in the right side are starting from the fourth intercostal space to the left side of the sternum, then V2 to the right side of the sternum. V3, of course, as usual, it is midway between V2 and V4, and so V4 is in the fifth intercostal space at the mid-clavicular line on the right side. And then V5 in the fifth space and the anterior axillary line, and V6 in the mid-axillary line. So the right ECG lead is the same like the left leads, but in a mirror image pattern. And so this is an example of a patient having a ST elevation in the right ECG leads. And then the posterior infarction, of course, it can occur with RCA or LCX occlusion, and that's why it may be showing normal resting ECG despite the patient having myocardial infarction. And it depends on the presence of ST depression in V1 to V3 more than or equal 0.5 mm with tall R wave, and this is a sign of posterior infarction. And if you put posterior leads at the time, it can show ST elevation. So in this case, V1 to V3 are like the reciprocal depression to that posterior ECG leads. And here we use a cut point of 0.5 mm. So here, for example, we can see leads of V7, V8, V9 continuing on the left side on the back of the patient. And so the posterior leads are very important because sometimes they may show evidence of ST elevation, and as we mentioned, here the cut point is just 0.5 mm, not 1 mm. This magnitude is enough to diagnose posterior infarction. And if you depend on V1 and V2 and V3 at the time, just ST depression of 0.5 millimeter with stored prominent R waves are enough to diagnose posterior STEMI. So, of course, we are going to discuss each one of these three clinical spectra regarding the STEMI, non-ST, and the chronic coronary syndrome. But of course, we are going to start our topic of ischemic heart disease with the STEMI. Thank you very much for listening, and wait for the lectures of the ischemic heart disease.